Hello, this is Matthew Lee presenting on Vagus Nerve Stimulator placement. Case presentation. A 30-year-old female with history of focal motor seizures and intractable epilepsy presented to the clinic for surgical evaluation. Her seizures were characterized by an abnormal sensation in the left index finger that culminated to tremors in the left arm. Patient has failed medical management despite multiple anti-epileptic medications. Pre-op MRI showed no structural abnormalities. The patient's case was reviewed in epilepsy conference. Patient was felt to be a good candidate for neuromodulation. Surgical options and complications were discussed with the patient, and VNS was chosen. The patient is taken to the operating room and placed under general anesthesia. The left side of the neck and chest are prepped. A linear incision is made along the mid-cervical crease. The platysma muscle is divided and undermined. Medial to the sternocleidomastoid muscle, the carotid sheath is identified. The sternocleidomastoid muscle can then be retracted laterally. The overlying omohyoid can be retracted superiorly or inferiorly to assist with visualization. The ansa cervicalis is preserved. The carotid sheath is opened. And the vagus nerve is seen lateral to the internal carotid artery between the artery and vein. A right angle is used to expose approximately 2 centimeters of the nerve. This allows for safe placement of the electrodes later. A single vessel loop is used for dynamic retraction. A linear incision is made along the left chest wall. A pouch is created for the generator. Then a tunneler is used to connect the neck and chest incisions. A cable is run underneath the skin through the tunnel. With the help of a right angle, the electrodes are placed on the nerve in a stepwise fashion, starting cephalad and traveling caudally. First the negative electrode, then the positive electrode, and finally the anchor is secured. The vessel loop is then cut and removed. A few centimeters of cable is pulled into the cavity to prevent any tension. The cable is then secured to the deep cervical fascia. The generator is then connected. A test stimulation is performed to confirm adequate connection without adverse effects. The generator can then be internalized and secured. The incisions are then irrigated and closed. Follow-up X-ray showed adequate placement of the stimulator.